And now Dr. Tricia will introduce to us the main hot topic, the rescue medication in epilepsy.
Good morning. My name is Tricia Ting. I'm a professor of neurology, adult neurology at Georgetown University Hospital in Washington, D.C. It's a real pleasure and honor to speak to you today. For me, it's the second time speaking at this course, but I wanted to tell you a little story before I start. You know, I'm Chinese in heritage. I was born in the U.S., but I always grew up very proud of my heritage because why not? You know, we came from many dynasties of the Middle Kingdom in China, and we built the Great Wall, 2,000 years old, in the 700 BC. So very proud until my first visit to Egypt a few years ago. Then my mind was blown. Now I'm a big fan of the Egyptian ancient civilizations, and I'm so proud to be able to speak to you again and to visit. I'm learning so much, so thank you again. So today I'm speaking about seizure rescue therapies, and I hope you'll take away today the importance of thinking about seizure rescue therapies. It's really taking off in the US, and I know that it's a great need in other parts of the world. So think about the importance of talking about seizure rescue therapies and coming up with the right ones for your patients. And how do we look at the different types, and what are the advantages of certain therapies, and what agents are we going to use? But first off, the importance of it. We know that more than 50 million patients with epilepsy worldwide. The World Health Organization estimates the active epilepsy patients at a prevalence of 4 to 10 per thousand. And when we look at studies, for instance, in Egypt, it may be on the higher end of that scale, especially in the rural areas. This is one study I found really amazingly done in Fayum, because it might really capture a more accurate prevalence of epilepsy. This team went door to door in Fayum and knocked on every household in order to gather the data on who might have epilepsy. Very impressive. And they came up with active epilepsy prevalence of nearly 7 per thousand. In addition, very similarly, this study found that there was a prevalence of epilepsy in Al-Khazir at, again, 5 to 6 per thousand. But what was also impressive from this study was that they found a huge treatment gap. And this is this way in many parts of the world, including China. But 84% of the patients may not be getting really standard of care or access to the best treatments for epilepsy. So let's look at what's important for getting treatment, right? Someone's having a seizure. Remember, this is, for many people, a medical emergency, a neurologic emergency, especially if it's a more severe seizure, one that lasts longer. And so we know that people need access to treatment quickly. When we don't have a lot of information about how quickly a person with seizure may be able to access emergency services, but we can look at what other specialties in neurology have looked at, which is what's the, or just in medicine, what's the access for, say, something like heart attack? Everybody knows, you know, that we have to get very quick access. And so when they looked at, you know, parts of the world, how quickly they can get access to emergency services, you can see they surveyed many different countries, and this different darkness of blue tells you how much data points they got, how many people answered. You could see that even Egypt was part of this survey. And what they found was, for instance, in most of the data points, which is China, which is vast, that it took these patients maybe 4 hours to get emergency services, to get to the hospital from where they were, okay? The difference is in the US, for most patients in the US, if they call 911 or emergency services and try to get to the hospital, EMS, the ambulance will arrive in less than 10 minutes. It's somewhere between 6 and 20 minutes they can get emergency service right on the scene. That's clearly not the case for many parts of the world, such as China, such as parts of rural Egypt, for instance, to get to help. And why is that important? Because rescue therapy can save lots of lives, especially when people are far, far away from their facilities. If they have a home treatment, that they can give themselves, you can really make a difference in mortality and morbidity. Especially when we're looking at the population of Egypt, you probably have many more than 500,000 patients with epilepsy. If even 15% of them have seizures that are more severe that require rescue, we're talking more than 100,000 patients who could benefit from seizure rescue therapy. And again, as you know, this is kind of not rocket science, but if you can give people a tool to use to stop seizures at home, they're going to have fewer visits to the emergency department. The reality is, how can they even get there for many people? They'll have, they face a risk of status epilepticus, a true neurologic emergency, of prolonged seizures, or even acute repetitive seizures that just don't end, right? They don't really come back to themselves. And then it is associated with almost a 4-time greater mortality or risk of death if they don't have access. And the reality is, what about the patients themselves? They know that they don't always have control over their seizures. They know that they can't be sure, almost like a bad lottery. They don't know when that one seizure is going to be the bad one, where they won't stop seizing or they enter a cluster of seizures. It really affects their mental health too, their well-being. 75% of patients who have seizure clusters live in fear. So how do we address it? What is the guidelines? Well, we have our own professors here. Professor Nermeen and Professor Hassan came together with a consensus guideline on the management of epilepsy in Egypt. And I wanted to hone in on the one part of this guideline which talks about emergency treatment recommendations. So we do know from many of our published studies that it is important to treat even before they get to the hospital. We know already that it takes a long time to get to the hospital. It takes a long time for emergency services to get to you in the home. So it's important to think about pre-hospital treatment, and I'll show you some studies, such as the New England Journal, that show the importance of getting treatment before you get to the hospital. And if they get that kind of treatment, what are the possible access points? So you can do IV therapy, you can have intramuscular, like a EpiPen kind of therapy. They can get a rectal gel, like diazepam. You can have a buccal administration, or even nasal spray, intranasal benzodiazepine. And what kind of therapies among the benzodiazepines? I highlight this, many of us are familiar with diazepam or lorazepam, and we'll look at sort of the spectrum of the benzos in a moment. But I wanted to highlight the latest is many people are widely using midazolam as a rescue therapy. So let's see what the difference is, because many of us, until recently in the practice, we might kind of inadvertently kind of throw different benzos at patients, what might be available, what they have already. But there's a difference between them, right? And a lot of it's a class very useful for seizure rescue, but they have different longevity, duration of action, and most importantly for seizures, because we want medication to be absorbed quickly and reach a peak effect quickly for the therapeutic advancement. So here, you can see in the beginning, this is a summary putting all the benzodiazepines we use now up against each other for Tmax. How quickly do they reach Tmax? And there is clearly a difference. When you look at clonazepam, we're looking at a Tmax 1 to 2 hours. Now, how long do most seizures last? Right? Most seizures are a matter of minutes. So, and even if you have something like acute repetitive seizures, you don't want to wait hours to prevent even the next seizure in the cluster. So that brings us to the diazepam family, and this shows the different formulations. You have PO, the oral, you have intramuscular, you have rectal, you have nasal, and they're pretty good, but even then, you're looking at a Tmax that is close to an hour, maybe slightly before. So again, is that going to be that useful when you have someone seizing in front of you that even 10 minutes of seizure is a long seizure? So later on, we're going to look at some of what came with the diazepam family, and then later on, maybe we will start to understand why midazolam is becoming more the drug of choice for seizure rescue. Because look, it's a faster Tmax, more in the matter of, within a half hour, okay? So what is it in seizure rescue that we really want to, features that are important? Well, the features I mentioned before, you want a drug that becomes active and gets absorbed very quickly. We want the Tmax to be as quick as possible, rapid onset. We want it to be easy to administer, because if patients are going to be doing this before they reach the hospital, they're going to be on their own. It might be the patient's family, the parents, maybe people around them, their friends, if they're in school. So it has to be someone who's not medically trained, and that means it will be harder for us to have IVs, right? Only the emergency service people in the ambulances are able to struggle to get an IV in, or a nurse can get the IV in. But most people, even in the nursing homes, the elder homes, they're not going to be able to administer complicated types of medication. And lastly, we want them to be effective, of course. These are some of the common types of benzodiazepine formulations: oral, IV, rectal, nasal, intramuscular, or other. The other issues about administration, not only do we have to think about the caregiver and people who are giving the seizure medicines, but we have to think about the feasibility of getting that medicine into the patient when they're seizing. So what's happening when they're seizing? Well, many people are unaware. They're not able to cooperate. They may not be able to swallow while they're seizing, if they're staring off or drooling. And then if they're convulsing, even more so, they're at risk for aspiration. It's hard to, someone who's stiff, who may be more heavy, and we're not talking about pediatric patients, maybe more adults, hard to get them, turn them over, administer a rectal gel. Just think about the reality of giving these medications. This is a diagram of, many of you are aware of Diastat, or rectal Valium gel. And it's pretty complicated, and just the picture of it alone is a little bit embarrassing, right? Can you imagine pulling this out and showing a patient in their clinic, this is what I want your mother to do to you, or I want your loved one to administer to you? How embarrassing it is for them. And for them to think about, what if I was in school? What if it's a teenager? I'm in school. Can they ever show their face again? Or if it's a young woman, how would she feel in a shopping mall having something like this given to her? So and not only that, you can see that it's very hard for clinicians who are busy. You have 50 people in your clinic. You have to sit there and calculate different dosages for this. Also, think about the feasibility of telling your patient, telling the pharmacy, how am I going to adjust this by weight? So this kind of complications with what we had, which was rectal. Rectal's great because you don't have to worry about someone swallowing medicine or having aspiration. It works feasibly, especially for the young ones, but has the social stigma. It has other issues with the reliability, because rectal gel can run out of the anus if you don't hold the butt cheeks together. Like it's not so easy, right? So let's go to the other end. Let's go to the nose. And that's what people started to do. It's less invasive. It's less embarrassing. It's a quick spray. It's a very, vascular surface. And then you avoid the first pass phenomenon of taking something orally. You don't have to worry about intestinal metabolism and liver metabolism. Moreover, there's a prospect of direct entry into the brain, as shown here, through the olfactory nerve, through the trigeminal nerve. You kind of have a direct route. And when you'll see later some of what has been developed since and is available in the US. Sometimes I tell my patients who I know, if they have a right temporal lobe epilepsy or left temporal lobe epilepsy, I kind of aim for that one. So there's one medication, which we'll see in a second, which is intranasal midazolam, that the dose is just one spray. They can have a second spray for rescue if they need it, but one spray is the standard dose. I tell them to aim that toward the side where I think their focus is, because I want it a little faster to get to where it needs to go. So what's troublesome about the nasal formulations? Well, you only have this big a nose. It's kind of small, at least for the Chinese, right? So you have a limited nasal volume. You might not administer it perfectly, you know, if you're trying to struggle. So there's a variability potentially. The mucous membranes in the nose, you know, it's trying to keep out germs. So they have very tight junctions that can impede, you know, adequate absorption. And we'll see what happened in one of the clinical trials for one formulation of diazepam to get nasally, that there was some issues with this tight junction holding the medicine from getting absorbed. And lastly, it is a little bit nasty, sort of like the migraine nasal sprays, as we're going to hear about migraine rescue. You know, it can be pretty distasteful if the patient's kind of aware, and it also is very caustic. So this is a picture of mucous membrane sort of ulcers from administration of some of these agents. Can be very burning of the nose and cause problems. So when we did one of these studies in nasal diazepam in the US, we had to rate people's ulcers who were in the clinical trial. That's how caustic it is and difficult. And that's this study. So this actually was a study failure. In the US, if you have a medicine that's already being used widely, that's shown to be safe and effective and labeled and approved, you can fast track a new formulation if you can match its PK sort of behavior, the bioequivalence, so to speak. So Accorda thought, oh, you know, we have this need for nasal rescue. Let's take the rectal diazepam and stick it in the nose, and then show that the peak, you know, the Tmax and the PK is equivalent to the rectal absorption. And then if we can show that, then we can fast track and get this into the market. But as it turns out, there was, it wasn't bioequivalent. There were some issues with safety and tolerability, like the mucus ulceration, and they had an unexpectedly low nasal absorption of diazepam in epilepsy patients. And we think it's because of those tight junctions in the nasal passages. So along comes Valtoco, a different company, tweaking it a little bit. They're like, we'll take Valium and add some tocopherol, vitamin E, add some DDM, add some agents to help it penetrate that mucous membranes, the tight junctions, and see what happens. And lo and behold, they got it. So they were able to show the bioequivalence, and whoops, and they were able to get labeled. And so, you know, many of you may be familiar with Valtoco as a nasal spray of diazepam, frequently used now in the pediatric population. And it's been FDA approved in the US since 2020 for greater than 6 years of age. The caveat is there are many different boxes of many different doses, kind of like the rectal gel I showed you. You have to calculate by weight, and it may be one kind of size box or another, and it might be one spray or two. So in my opinion, sort of confusing for patients. Because as that child grows, you have to keep telling them, oh, now you have to rescue them with 2 sprays, or now you need this new box and just do 1 spray. So you can imagine how confusing that might be. Plus the fact that it's Valium or diazepam. So we saw on that chart that the Tmax is reached a little later than, for instance, midazolam. As a class, for all these benzos, whatever formulation, but including the newer nasal sprays, we have to remember, as easy as it is to give, as important as it is to rescue someone, that we do always in the back of our minds worry about some risk, especially in patients who are already on lots of opioids or high doses of benzos at baseline, that we should be careful and warn the caregivers that we have to watch for respiratory distress, you know, not protecting their airways, or having some, with overuse, developing some dependence on the benzos. The reality is, when they've done sort of outpatient, large-scale follow-up, there have been minimum risks of respiratory distress in the trials and in regular use. Really, you're rescuing these people from very dangerous seizures. So it's worth the potential theoretical risk of this respiratory depression. And people generally, at least in the US, they don't let you fill these rescues very much. So in 1 month, they let you, get 5 spray boxes. So really, the risk of developing a dependence and addiction is also pretty low. So another form that, if we move away from the nasal spray for a moment, another form to consider would be intramuscular, the EpiPen, okay? And this actually has been already developed by the US Army to rescue their troops in the field, to get medicine through their fatigues without having to take any of their uniforms off. And they developed this really as a nerve agent rescue. So they found that they added multiple agents. Diazepam is one because the nerve agent can increase risk for seizures, as well as they would give atropine and oxime. And you could see they would put it all in one pen, so it's a one go. So they started to look at this possibility of using IM diazepam for seizure rescue. But think about it. Most patients aren't going to want to give themselves an intramuscular, or their loved one, an IM injection for seizures because they happen fairly frequently, unlike anaphylaxis for epinephrine. They did find, when they compared it to rectal formulations, that there was a more rapid and less variable absorption if they gave it IM. Remember, I mentioned that the rectal formulation can have some variability if it leaks out. So it's definitely something that could be absorbed and useful. And so it was approved by the FDA. They showed it to be safe and useful. But the reality is, no pharmaceutical company wanted to develop this for commercial use, because I think it makes sense to everybody. How many people want to give themselves an auto injection or give their loved ones one? So it never really became commercially used. And so this is where I want to start the focus on the next group or class of benzodiazepines, which is midazolam. You can see how quickly, compared to the other formulations, compared to diazepam, it reaches a Tmax. And you can see that the intranasal formulations are even among the different, versus oral, your intranasal is going to reach a Tmax faster. It doesn't have to be absorbed as long as a pill might. So what led to sort of what I think is the push for using midazolam? This is the one where we looked at it in comparison to the standard of care at the time in pre-hospital setting, and it was published in the New England Journal. And what they did was, it was a multi-center study in the US. I participated as one of the PIs in Baltimore, and I had to go from paramedic, from one EMS house to the next, and train the paramedics to administer this as a placebo-controlled trial. They were, not placebo, I'm sorry, as a controlled trial where they were randomized between the IM midazolam as a sort of EpiPen device you can see there, versus IV lorazepam, which was standard at the time. And when they were randomized, each patient would get both an IM and an IV, and one of them was dummy. So you wouldn't know, the EMS people wouldn't know. Then the EMS people at the time, how long did these people take for their seizures to stop? When they arrived at the scene, they were seizing, they gave them this. How long did it stop? And how many of these people had to be intubated, when they got to the hospital? How long was their time in the hospital? And as it turns out, the IM midazolam at the time really was equivalent to lorazepam in its efficacy to stop the seizure. There was a significant non-inferiority, even superiority, and it was equally safe. And as it turned out, It was a route that was preferred by the paramedics. These are the EMS people who were administrating it. It also had advantages for shelf life. So this midazolam did not need to be refrigerated like IV lorazepam, so that was more practical in use. And as it turns out, the people who got to the hospital, they had less need for admission if they got the IM midazolam than if they had the IV lorazepam. As a result, now in the US, widely used is midazolam by our paramedics. And when we look at overall usage in 2019, you can see that 83% use of midazolam as this rescue. And again, the time from dispatch to medical administration was less than 20 minutes. It's very commonly used now. So how about this? You know, they showed in this New England Journal trial that the IM midazolam is so great. Why aren't we having that around? I waited for this forever for it to be available for my patients who could really have benefited. But similar to the IM diazepam, nobody wanted to take it on as a commercial option. So that's not available. But they do have marketed this Ceazolam, which is a little vial of midazolam that people can draw up and administer themselves. Okay, this is, again, not something that most people do, not in the US and not here, for manual intramuscular injection. But this could be an option if you need to make your own nasal spray. So let's look at what nasal sprays are available for midazolam. So UCB Pharma, the same company that brought us Keppra and Vimpat and now Briviact, has gone ahead and developed this as a nasal spray, a one-time use metered nasal spray of intranasal midazolam. They did a placebo-controlled trial and showed that this medication was able to stop seizures from becoming clusters, and also that patients tended not to have another seizure in 24 hours even, and had a sooner recovery to their baseline. So that's what it looks like, very much like any other rescue like Narcan for opioid crisis. So it's already set to go, and all the patients aged 12 to adult have the same dose. There's no calculating on a table based on weight. And the dose is one spray in one nostril, and if they need to, in 10 minutes, they can have a second spray in the other nostril. So either 5 milligram administration or 10 milligram administration. And when they looked at, after approval, how this behaved in use out in the public, they found that it was not associated with more addiction and more need or dependence, and it didn't have a wearing off effect. So if people were rescued by one spray, after 2,000 rescues, many of them did not need a second spray down the road. One spray kept working for them over several years. It didn't show that they developed a need for more and more. Okay, and moreover, they wanted to look at what this affected patients' quality of life and their caregivers' quality of life. So when they started looking at scales of anxiety in these nasal spray trials, they found that people from the beginning of the trial and near the end tended to have less and less anxiety because they were used to having something they could turn to, a nasal spray, to stop their seizures when they were going about their lives. So the question is, as I want to wrap up, like, what's the future coming for us? Is there anything faster than this, right? So all these Tmax and kind of getting into the body, we're looking at things that are at best working within 10 minutes, 15 minutes, in that time scale. But most seizures are even shorter than that, especially the bad ones. Is there anything more? Well, yes. So now what's been in development also by UCB, who bought this company Staccato, is vaping, aerosolized alprazolam. And this is kind of how it works. They just pull a tab and this battery heats up and it aerosolizes the alprazolam that gets sucked into the lungs, as this picture shows. And what's important is it does not need to be actively inhaled. As long as you kind of put it in their mouth and put their lips around it, these people, if they have a passive inhale, it immediately goes into their lungs and very quickly gets to the brain. They found that we did these trials as well in our EMU, and we could see patients seizing on the EEG. We could see them seizing clinically. The second they got this, within seconds, their seizures stopped. So we go from, Tmax of an hour, Tmax of half an hour, Tmax of 10 minutes. Now we're getting down to seconds, which is really impressive. So yeah, oral tablet may take 20 minutes to work, and then, oops, I was cut off. And get a password here. I'm almost done. Yeah. Just go back a couple. Yeah, thank you. Yeah, so intranasal rescue, 10 minutes, right? But an inhaled alprazolam, let's watch for it. It's a matter of just a few seconds. So just remember, the take-home points is we have a lot of patients who could use the seizure rescue therapy. We're trying to prevent mortality from the worst kind of seizures, the prolonged seizures or clusters. We're trying to prevent status epilepticus and their need to get to the ER. Not only filling the ERs waiting to be seen, but they can't even get there in many of the rural areas. There are some formulations that are better than what we've had, like this rectal gel. And what at the moment, the best we have, I think, are the nasal sprays, if it's not administered by a paramedic or something that's IV, which even at that point, nasal spray may be better because it gets in there very fast. You may or may not have it right now in Cairo, but like I mentioned, some of my patients before Nasolam came about with a already ready-to-go spray, they were compounding it. They were making in the pharmacy with the little vial, and that you can buy these little nasal sort of tops on it, and they can, their caregiver can pull up the vial into the syringe, put a little nasal adapter on it, and just administer it on their own. Make their own version of Nasolam, so to speak. Okay, something to think about. And I really appreciate your attention, and looking forward to speaking to you again.
First question by Professor Dr. Sahir, please.
Thank you very much for this nice comprehensive treatment for fits. I just call it fits because we don't know are using for the first fit or patient with many fits or right. Patient with status epilepticus.
Right.
If it is in the worst case scenario, and the patient is not responder to the treatment, what are going to do? You mentioned ER in a hurry, but I feel we're waiting for what is after the first treatment, or right. What is if not responding, what you are going to do. Second question, did you measure hyponatremia in such a patient?
No. So let me answer the first.
When a patient is not good responder or passes into status epilepticus, do you test for hyponatremia?
Well, we definitely want to, when someone's in status, frequently there's a reason for it. It's not just pure epilepsy. So definitely we want to know if it's a provoked status, if there's a abnormal metabolic derangement. You must treat the underlying cause of the status, as you said. We have to search for it. Is it hyponatremia, or is it hypoglycemia or hyperglycemia? We definitely have to do a host of tests when someone's in status in the hospital. At home, there's no way for them to know, right? Unless it's like, unless they really know their patient very well and they have a history of dropping their sugars and stuff. So at home, you want to do your best to give them as much benzo as you feel safe giving to them. The reality is, as you mentioned, it's better to get it controlled before they get to the hospital. you're going to trigger EMS, but you're going to be on your own in some parts of the world 4 hours. So you have to come up with a plan with your patient, what you feel comfortable as what their tolerability for that benzo is. Many of these standard treatments, you do give a second dose. It's part of the standard. So for instance, the Nasolam is 1 spray, and then if in 3 minutes they're still seizing, then the other spray. We know that that's been safe. They've looked at these patients. People are not going, having to be intubated out in the field. You're rescuing them from a seizure that could cause respiratory, trouble. So it is important to be pretty aggressive with these treatments and to repeat them as you need. I don't go beyond the 2 sprays that's labeled for instance, for Nasolam. So I do repeat them, but at some point they have to make it to the ER. There's not a lot of fix on your own for real status in your home. But we will be hearing very shortly about status epilepticus, so this is a nice transition to that. Yeah.
Any more questions? So دكتور عزة عباس اتفضلي.
Thank you very much. At the end of your talk, you suggested to do your own intranasal. How do you
I
adjust?
only said that because I was trying to look up if you have in Cairo, maybe you tell me, do you have access to the Valtoco or to Nasolam now? I don't think you do.
You mean the apparatus itself?
No, I'm talking about the meter, the already ready to go spray. So short of that, if you have to tell me if you can access midazolam in the vials, or like have your compounding person make it, then you could potentially find the right dose for your patient, which is somewhere around 5 milligrams or 10 milligrams. Some of my patients used to use more because they were just used to benzos, so they would give themselves more. Yeah.
Adjust the dose.
You do have to worry about the dose. But they have to know. They have to pull it up to the right part of the syringe and give it. Yeah. So that's why this ready-to-go commercial formulation is better, because they don't have to worry about that, for sure.
Thank you.